Thank you for joining us for another episode of Doc Talks. Dr. Tennant, we're going to go. We know that we have a full
Right.
road ahead, so we'll go ahead and let you take over. Thank you so much, Doc.
Great. Uh, Again, welcome to Doc Talks. We've taken a little break for a few days because of some events that have happened nationally that are quite profound. And we felt we needed to do a little reorganization of this show to be more effective in meeting our goals of bringing diagnosis and treatment of severe chronic pain to every community, as well as being an advocate for patients. Uh, and so we'll get to a lot of the new format in just a little bit, but we're going to start off as usual with a little educational message from me. Uh, I want to talk about tonight one thing, and one thing very clearly, and that is we still have in the society an awful lot of negativism of trying to treat some of the severe chronic pain causes. We have an awful lot of negativity that anything can be done and that patients are just drug addicts, and you know all of these things. The truth of the matter is we've made great progress in dealing with these terrible conditions in recent years. Now, a lot of you who see this are aware of something that we call the three-component protocol for the treatment of adhesive arachnoiditis and other causes of severe chronic pain. Now, you may not quite know what the protocol is or where it came from, so I'm going to give you a little rundown on it and what I'm here to tell you and to showcase in a couple of minutes. The idea that this is a kind of a protocol or roadmap for lifetime treatment of these conditions. In other words, we're not talking short term here. People who watch this show, and those of you who are tuned in, know that severe chronic pain is likely to be a lifetime situation. So, how did it all get started? Well, first off, uh, I'm here to tell you that it's literally been 40 years, maybe, long time ago, 1970s, 1980s, as we started to treat severe chronic pain. And incidentally, in those days, everybody liked it. Law enforcement, medicine, everybody was for us. That's changed, obviously. But nevertheless, back in those days, as we took patients into treatment, regardless of the cause, whether it was interstitial cystitis, chronic pancreatitis, post-polio, post-herpetic neuralgia, whatever it was, we would take blood tests even in those days, and something interesting showed up. They had autoimmune markers. In other words, we had a panel back in those days, something like a sedimentation rate, what they call a C-reactive protein, lupus test, rheumatoid arthritis test, and we had something in those days called an ASO, an anti-streptolysin O titer. And what was interesting was these pain patients would have some of these positive. And so we didn't quite know what it meant, but we knew one thing. It reflected something to do with autoimmunity. Now, keep in mind that in 1975 or 1980, autoimmunity was a brand new concept. The word autoimmunity didn't even show up in medical dictionaries until in the 1960s. So it was a new concept, but we knew there was something about autoimmunity and pain that long ago. Now we move forward, and as time went on, we decided that you better figure out something else. And interestingly, the thing that stimulated interest in inflammation in pain patients were studies in the early part of this century, around 2005, 2010, that showed something called neuroinflammation. Now, this was a new term, but what it meant was that you had inflammation. I mean, you had tissue destruction, heat, disruption of tissue in something called the glial cells. And glial cells have subdivisions called astrocytes and oligodendrocytes. And you don't need to know that, but you do need to kind of know the term glial cells. And so these glial cells demonstrated neuroinflammation. And so it was a mystery. Now, this patient's got pain, has got neuroinflammation. What's going on here? And so about 10 years ago, a brilliant virologist by the name of John Belilo and I teamed up to do inflammation tests in adhesive arachnoiditis patients. And lo and behold, we found out, oh yes, this is an inflammatory disease. Markers were off the map. And so the concept, literally a decade ago, emerged that we're dealing with several factors. We're dealing with autoimmunity. We're dealing with inflammation. We're dealing with neuroinflammation in the nervous system. We're dealing with nervous tissue breaking down and becoming dysfunctional and disruptive and not able to shut down pain. And therefore, we started calling it intractable pain, centralized pain, central sensitization. You've heard all of those terms. But the fact was, we had various causes of severe pain. We had autoimmunity, we had inflammation, we had tissue destruction. And so we thought, no, the way to get people to buy into this, we need a roadmap, something simple. And so we didn't do anything except current treatment and put it in components or categories. And so what emerged some 10 years ago was the 3-component protocol. Now, we're going to read that. It's three parts, 3 components. Number 1, you've got to suppress inflammation and autoimmunity. Number 2, you've got to regenerate damaged tissue. And number 3, you've got to control pain. Now, if you don't control pain, the other things don't work very good. That's sort of the first step. People who do have uncontrolled pain, as you know better than I, they can't eat, you can't sleep, you can't think, you can't function, you can't exercise. You're not even going to participate in the other 2 components. And so why control of pain sort of is number 1. But again, let me repeat. I've gotten kind of noted as being called the Tenet protocol: suppression of autoimmunity and inflammation. Number 2, regeneration of damaged tissues. Number 3, control of pain. Now, really, this is a roadmap. Now, it's not just medicines, and that's an important point. For example, we love diets that are both have protein in them to give you a little regeneration of tissue, plus something that creates a little anti-inflammatory reaction. We love exercises, which are going to build some muscles, build some tissue. We like spinal fluid flow because that's going to move inflammation out. These days, we love some of these electromagnetic therapies to help on that. In other words, we're not just talking about medicines here in this protocol, but measures. And I have one message for anybody who's got severe chronic pain. Every medicine, every supplement, every exercise, every social interaction you do, ask yourself, what component am I in? Okay? Why am I doing this? And you need to be able to answer the question that those supplements you're taking in the morning, that medication you're taking, that water bath you're taking, that long walk you're taking, what component does that fit in? And it's a nice kind of fun thing to do, but it'll also help you realize you got to have all 3. Now, what I've got to go to next is something that I normally don't like to do, and that's read a long letter. But I have a long letter that I want everybody to hear because for 2 reasons. Number 1, what we call the 3-component roadmap or protocol goes on for a lifetime if you have a severe chronic pain condition. And secondly, to dispel the myths out there that things like adhesive arachnoiditis cannot be treated. Okay? All right. Now, this letter came to me here a few days ago, and it's a little long, but I'm going to read it because it kind of summarizes everything that I'm preaching and teaching. Okay? Now, it starts off, hi, Dr. Tennant. Nobody says dear Dr. Tennant anymore. It's hi, and I appreciate that. Hi, Dr. Tennant. It says, this is AW, your friend from Dallas, Texas. I wanted to check in with you and let you know how I'm doing 7 years after I began the Tenet protocol for severe late stages of both lumbar and cervical adhesive arachnoiditis. In May of 2023, I began being able to drive again consistently and without severe flare-ups. This was life-changing and one thing that had kept me mostly homebound for almost 8 years prior to that. I still take ketorolac injections 3 times a week in addition to a low dose of dexamethasone. I still use narcotics as part of my pain management, but at a much lower dose than when the journey started. I also make sure to incorporate treatments from all 3 columns of your recommendations. Incidentally, I used to put out a paper of columns of each component. I think I should go back to that maybe. Anyway, going on. I get labs drawn every 6 to 12 months to see if anything needs to change in my treatment approach. We monitor my hormone levels, thyroid, inflammation markers, CBC, CMP, Epstein-Barr levels, and other vitamin levels as needed, such as D, B12, and B6. I began in-home physical therapy in fall of 2022. I continue on my own now with a simple PT program 3 days per week, in addition to the daily stretching, movement, and rocking as needed. I have gotten so much stronger overall. Ups and downs happen, but I can work through them now. I also chose to change my diet when I was diagnosed with AA, and that is still going well too. I do not consume any wheat, gluten, dairy, or processed sugars. I use the Walls protocol as my guide with nutrition. I also discovered I feel my best without grains and legumes, without prioritizing consuming between 6 to 9 cups of veggies and fruits per day. I think another name for what I eat is referred to as autoimmune paleo diet. I still get pretty severe AA flare-ups after any viral illnesses. I have medical support when I need it, and we work through until I'm stable again. I do best when I prioritize rest and stay hopeful about my future. My 3 boys are much older now than they were when my health journey started. They are now 11, 13, and 15. I'm so excited to actually be more physically involved in their lives now. One of my prayers was to have the ability to sit in the bleachers at their sporting events, and I can now. Overall, there is so much to be thankful for. I still have ups and downs. A more recent flare did take me out of driving and needing a walker again for a couple of weeks, but I got through it. I also have some visible muscle wasting in my left calf and some new GI symptoms. I always assume those things are tied to AA, but I also trying to do my due diligence and following up with my care team to make sure nothing else is going on. Keeping a positive mindset is the thing I fight hardest for because it helps me get through these tough times. Thank you again for all you are doing to help our AA community. You and your team have done amazing work, and I pray you are always blessed with good health as well. I cannot tell you how many people I've recommended your books. They have all been helped as well. We are all so grateful to you and your work. Well, the last part's nice. Anyway, 7 years. And so she's doing well, and I remember her well, totally bedbound, totally disabled, both cervical and lumbar arachnoiditis. So I thought this is a testimony that people should hear because these diseases are not hopeless anymore. I want to move on now to the new format, if you will. As some of you know, we took a break last week, and a lot of the reason why we took a break is because of a couple of news articles that were kind of with me the last straw. This is it. We have put up with this propaganda stuff for years. We've sat here and put up with these opioid lawsuits, investigations, condemnations, proclamations. Doctors have been incarcerated, probably unnecessarily or unjustly, maybe. There's been all of these things. You can assign all this a lot of 4-letter words, if you will. And guess what? Most of us who are in the field really haven't stood up to it, haven't said a lot about it. We've griped. And thank gosh, we've had some top-notch advocates like Red Horn and uh, Kristen Ogden and some people, and we've got some good advocates here tonight that I'm going to call on. In a minute, I've asked some of our top contributors to this show who have opinions and who constantly advocate for us. Let me just tell you the two articles, and we're going to discuss this in a couple of minutes, that just I finally said, we've already started sort of a media watch here on the show, and we've also recognized all the propaganda out there, but these went over the top, okay? They went over the top because I really know what they mean. The first one was the untold story of benzodiazepine dependency. 30 million people take benzodiazepines, and if you have severe chronic pain, you're going to need a benzodiazepine or a related drug for pain relief. This, in effect, says no one should take them and you're going to get sick and what have you. Okay, it was called The Untold Story of Benzodiazepine Dependence. But the one that got me, and the one that, frankly, in my opinion, every doctor, every patient, every nurse, every psychologist, every social worker, chiropractor, advocate needs to understand something. Published in Pain Medicine News is a study entitled, that's an article, it's not a study, it refers to some so-called studies, Tapering Analgesics in Chronic Pain Linked to Positive Outcomes. What this says, believe it or not, I know this is hard to believe, it says that if you're now taking medications for chronic pain, you need to get off all your medicines so your pain will improve. Your medicines are causing your pain to be worse. Okay? Now, this is in the Pain Specialist newsletter. Now, what does this do? An article like this, since it's the physician's newspaper, what it does, in effect, say any physician is now medically justified in taking you off all your medicines. Okay? It's now medical standard. Secondly, to give every insurance company the right to turn all your medicines down and not pay for them because they're harmful. Now, this is really so ludicrous that it's we canceled the show, and I thought about what we're going to do. And so I've asked tonight for 5 people who have been great contributors to this show, to my own personal work, and to the welfare of patients and medical practitioners to come on the show with me. And the first thing I want to do is introduce you to them. Of course, all of you know my associate, Mark Ibsen, and my other associate, Scott Guss. But I've also asked Donna Corley to come on. She's a great advocate. Pat Irwin, you've heard from, and more people have talked about Pat. And then lastly, Dave Smith, who's got lawsuits going. So these are people who are really for us. And I thought that I wanted to get their 5 opinions to start with and then ask them to comment on these articles. And going on forward, we're going to be having a review of these public documents out there, including the National Pain Strategy and some of these other documents, which are being used to take pain care, good pain care, adequate pain care away from people, okay, or prevent it from getting it, or both. And so, but I can't emphasize enough that the public, I think if you went out, I'd hate to see it. I'd hate to see the public polled to see what they think of pain patients and pain doctors. I've got a sneaking suspicion that a majority of the public would say they're just drug addicts who don't deserve to be treated and our insurance shouldn't be paying for them. That's because they have been fed propaganda for 2 decades incessantly, each week. And I have no trouble finding one article after another in various media today that is denigrating pain patients, denigrating medication, and the medical practitioners who take care of pain patients. I have no trouble finding those articles. And at least on this show, we're going to try to have a different opinion, a counterbalance, hopefully. And we hope it's very good. Now, what I want to do is I'm going to start off with Pat Irwin. Now, Pat was here and has had this great success in bringing the tapering issue to us. And I want Pat, and I'm going to ask each of 5 people a question to start this format. And the question is this: what is the most deceitful or harmful propaganda declaration involving the whole pain issue, in your opinion? Now, Pat, are you there?
Yes, can you hear me?
Yeah,
Yes.
I can hear you. Now, I
Great.
want to hear yours, and we're going to ask your colleagues in a minute. What has bugged you the most? What do you think has been the most deceitful, dishonest issue or statement that has come down the pike here in the last 10 or 12 years?
Well, out of these 2 articles, it's very easy to say out of this benzodiazepine article, they only mention, first of all, the risk of benzodiazepines without any dosage. So is it a high dose? Is it a low dose? What's the other overall condition of the patient? And a recent study came out, this really irritates me. No one mentions this study that shows the risk of discontinuing benzodiazepine is higher than the risk of staying on. So it was JAMA in 2023. There's an article, and I can make sure you get this. Benzodiazepine discontinuation and mortality among patients receiving long-term benzodiazepine. The risk of being taken off is 6.3%. That's your risk of having serious complications, even death. If you stay on, the risk is high or moderately high. It's 3.9. But that does not consider, that 3.9 doesn't look at all on all of the other things we talked about. Is your dose high? Is your dose low? What's your other comorbidities? The fact is, when they rip patients off of the benzodiazepines, they don't even consider what's going to happen to that patient. What's the risk of going off? So for me, that on the benzodiazepines, that one is the worst. They don't even look at what the risk is. Then in terms of, the other thing, really quick, I know you've got other people to talk to, is
We'll be back to you.
okay.
You're not getting off with one comment.
Okay. You get back to me. I have one more thing, but you get back to me.
No, go ahead. You want a quick comment on the other article too? Because we're going to.
Oh, I was just going to say the other thing on this article is the benzodiazepine risk with opioids is lower than if you have a patient with benzodiazepine who has PTSD, combination there, or the risk of a patient with benzos who's on depression meds or anxiety meds, or heaven forbid, alcohol. Do any of these articles even, that's my real peeve, even look at the risk of alcohol? No, they don't. Not one of these articles will look at what is happening with patients who are drinking. That's my 2 cents.
Yeah, you seen any articles lately that says benzodiazepines might help your pain?
Absolutely not in these articles.
We'll be back. Okay, all right. Next up, Scott Guess. Are you out there?
Yes, I am out here.
There you go. Now you're our PharmD expert. You probably know more about benzodiazepines than any of the rest of us. But anyway, what is your other issue that has been deceitful, harmful to patients and practitioners? You comment on these 2 articles or other? What's your take?
Well, to answer the question that was posed, what's the most deceitful propaganda, was the fact that patients and providers are being blamed as the cause of the, and I put in quotes, opioid epidemic, and that all of our patients are going to turn into addicts, including the successful lawsuits against manufacturers like Janssen and Purdue, et cetera. When they first started talking about this opioid epidemic, I looked at a graph of opioid related deaths, and it's versus the increased number of people that were taking it, the prescriptions, and the overdose death line paralleled the increase in prescribing line. And what that tells me is it's a known adverse event, though tragic, it's a known adverse event for opioid treatment. And the percentage or the occurrence of that adverse event did not change. The raw number did, but the occurrence rate did not. But everybody got all excited because the numbers were greater.
Now, let me ask you a question. This has been a terrible deceit, that treating pain patients were responsible for the epidemics, the overdose.
Right.
And do you think that everything from our elected officials to the general public still believes this?
Oh, absolutely.
Yeah.
They keep, as I like to call them, they keep bringing out the parade of parents of dead children, and say how tragic it was that their child died of a drug overdose, and somehow that somehow as prescribers and providers and patients we're responsible for that, as opposed to the cartels.
Mm-hmm. In other words, they overdosed on illegal drugs, but pharmacists and doctors are responsible, right?
Right. Okay. Another one of the great deceits is they try and tell us that all of these people who died from an opioid overdose got their first taste of it through a legal prescription, whether it be a dentist or broken leg or whatever. And that just turned the tap open, and they wanted to keep continuing.
That's just baloney.
It's yes, it is. Well,
Yeah.
You live in Southern California with me. You're used to that big pile of Bandini,
Yeah.
out by the 610 and the 210 called Bandini Mountain. We all know what that's made out of.
Yeah.
Or you and I do, anyways.
You bet. All right, we'll be back to you, but absolutely no. I think you're right. I think the public does still believe, and I read something here just recently that there is a committee in Congress looking at overdoses, and they still believe that even though overdoses are way down, somehow the medical people and the pain patients are responsible. Yeah.
The other sad thing is to add to that is the young kids coming out of pharmacy school are in the same boat. They're drinking the same Kool-Aid.
Oh boy.
Yeah.
Okay. Let's go on. Is Donna Corley on? Where is Donna?
I'm here, Dr. Tennant.
Yeah. Okay, Donna. Boy, now, Donna, you've done so much for so many people. You were in fact, I could blame you for me being here today. You got me into this advocacy a long time ago. And anyway, we'll be back to you, but give us your pitch. What's the most deceitful, harmful thing about this whole scenario that bothers you?
There's not just one. It seems to be from every angle you look at it and every angle they push. They're trying to get rid of prescription opioids to replace it with something else that's going to make more money, is the way I see it. Also, with articles, I found it interesting with the first article where they were discussing how in their research that getting off of your pain medication would reduce your pain. It's supposed to, well, according to them, it improved, their patients improved, but it doesn't say how they improved. That's what I found interesting. Now, it said their mobility did not improve and neither did their mental state improve, but somehow they improved. Where did they improve? How did they improve when they were weaned off of their medication? I did not find anywhere where that was specific on how patients improved when they were weaned down off their medication.
Yeah. Did you happen to notice who wrote that study? In case you didn't notice that, the authors of the
Mhm.
are tied with the neuromodulation industry. They were paid by the
Right.
people who make implanted stimulators. Wrote this,
Mhm.
did
Right.
so-called studies. Yeah. Uh-huh.
Mhm.
Right.
Mhm.
Uh, oh, okay. Well, we'll be back to you. Okay. Next person is David Smith out here anywhere?
Yes, I am. Can you hear me?
We can hear you, David. David, again, we salute you for these lawsuits you filed. We did not realize how knowledgeable you are about these things, but yeah, you also, I've learned, keep your hand right on the button all the time and know what's going on. But, and you've experienced a lot of this. All right, give us your opinion. What's the most deceitful, harmful bit of propaganda that out there in the last 10 years or so that bothers you the most?
Wow. Well, I think the currently still going on in the propaganda and what you see on TV and what you see in the narrative in some of these films, and certainly coming out of the government, is this little slogan they have about one pill can kill, and the idea that everyone ever prescribed an opiate by a physician is equally at risk for becoming an instant addict to these medications. Well, that is just so preposterous and false. I don't even know where to begin with that nonsense. Addiction has more to do with socioeconomic and psychosocial factors, uh, and some say there's a genetic preponderance, but most certainly by the simple exposure to one substance on one occasion is absolutely not going to turn you into a raving addict overnight. So that's my biggest pet peeve of it all.
Okay. Uh, all right. We're going to come back to you in a little bit too, but that you're so right. One exposure makes you an addict. That's just, it's preposterous, you know? Okay. Thank you so much. All right. I
Thank
need the
you.
maestro. Where's the maestro? Where is my buddy, Mark?
Right
Mark,
here.
okay. I thought I'd let you hear those. All right. You've got a whole long list of deceits. You're an encyclopedia of what's gone wrong in this business. But do you have one at the top? Do you have one deceit or dishonesty that you think ranks above the others?
So I was going to mention the one David mentioned, so I'm scrambling for a backup. But I think the number one thing that's happening in the propaganda is well, I heard this from a DEA agent the other day in a recording, and he said that when you close down a doctor's practice, the patients behave like ants going to an anthill, and they just go to the next one, and that's where we go next.
Wow.
Which is it's so unbelievably effing dehumanizing, but it's also got a grain of truth in it. And the grain of truth is that pain isolates, and so does addiction. Addiction is a result of isolation. Uh, but if you're in an ant colony and your ant colony disappears, you are desperate to find the other members of your tribe. And this has become tribal. One tribe says opiates are terrible and you're going to catch addiction like a disease, like an infectious disease. And obviously, the CDC is about infectious disease and they have no business leaving their lane to try to handle pain. So I think the biggest lie is that pain patients don't have any choice, that pain patients are driven by some uh, instinctive, primitive thing to go to their next pain doctor, and they're driven there, and that the DEA should follow them and arrest them the next time.
All right. Now let's take this a step further, and I want to hear from the other panelists about this too. Do we have, what is the motivation? Okay. I mean, we have, it's easy to say money, but is there some money for who? In other words, you say money, but who's this? Who's paying for this? Who benefits monetarily from this drive to stamp out opioids in pain patients? Who's going to benefit financially from this?
Well, from the DEA perspective, Dr. Tennant, it's certainly the DEA and the attorney generals are fighting for their presence and their worth in the government, and the more their metric, that what it's worth to them is their metric where they can show their bosses, oh, look, we arrested another 1,000 doctors. As a matter of fact, if you look at the latest DEA newsletter, they were just joyful. That was the top headline. Another 20 doctors have been arrested. They want that metric. What's in it for them? All of the kudos and the money that comes for their salaries and bigger offices and more prestige. They're in it for that. Certainly there's some personal money that's involved when you talk like about Suboxone and who's making money on that. That's a whole nother story. But I really think a lot of it is about personal prestige of these individuals at the DEA and the Attorney General's office.
Sort of a notch on your gun, right?
Yeah, absolutely. Absolutely.
Uh-huh. Yeah. What, Dave, Donna, what do you think about this notch on your gun theory?
I think she's right in that aspect, but I also think it goes a step further than that, since we have had, and this really gripes me to no end, and them calling it the opioid epidemic when it's illicit drugs that have been flooding our country for years now. That it sends a false message, because whenever you say opioids, you automatically think prescription, and we're not dealing with prescription, we're dealing with illicit. But I think by them using that propaganda of, opioid epidemic, then them going after doctors and making it go a step further and look like that's the problem. I think that's the issue too, to make people actually think that they're doing something about this epidemic that we're having, when in fact they're not. They're doing something about it, all right. They're hurting legitimate doctors and patients, but they're not going after the real issue, which is illicit fentanyl that's been crossing our borders. I think that's another side of it too.
Who do you think is benefiting financially? We've heard from Pat, and she makes a point that I certainly agree with, that it's not just money, but notches on the gun. Who do you think is benefiting financially from the assault on pain patients, opioids, and doctors?
I think it has a lot to do with the new medications that they're coming out with, that they're pushing now, in place of opioids.
Can you name some of those medications?
There's one Suboxone I've heard a lot about. Suboxone, I guess that's the way you pronounce it.
Mhm.
That they're really pushing in place of opioids. And what little bit I've read up on it, that is just as addictive, if not more so, than the actual opioids that are being prescribed now.
Mhm.
But that's, from what I hear, that's what's really being pushed now, is the Suboxone in place of opioids.
Scott, David, this Suboxone issue, how big of issue is this?
I think I personally, I like Suboxone. It works really well in a group of patients who have decided to use medications recreationally, who no longer want to do that. And granted, it's substituting one opioid from another, but for people who've been using street drugs, it is a way to move from the illicit lane into the legal lane, put their life on a path where they can, get work and get jobs, and, not spend every dime they had trying to buy, very expensive street meds, when they can get the Suboxone covered. It does Suboxone, despite the fact that we have a medication that's targeted for pain, it's not a very good pain medication.
Yeah. Now they now want to even have this term opioid use disorder, and now they even want to have prescription opioid use disorder.
Yeah.
Tell me about this disorder business. What's your opinion about that? And exactly how do we define opioid use disorder? And is this just an excuse to get people off their Vicodin and their Tramadol and oxycodone? Is that all this is?
I believe it is. I don't know what the purpose is, why they think that is a necessary thing to do. I've liked the old definition of opioid use disorder that we've used forever, which is continuing use despite causing harm. And if we're not causing harm, there's really not an issue. There's not a disorder. And that could be used, insert food, shopping, sex, anything you want for the term opioid. Anything you do that continued use causes harm or detriment to the family or your community, it could be is a disorder. It's an overuse disorder. But focusing on opioids like this at the cost of patients with chronic pain, and poor Dr. Kubler-Ross is probably spinning in her grave because the end of life patients have been put in this category too. We're not even treating end of life pain anymore.
Yeah, absolutely. Yeah, David, I'd like your thoughts about this Suboxone issue.
Yes, sir. Well, concerning the who benefits question, I think there are multiple people who benefit, and that's right on the money. These pharmaceutical companies who have now come up with the alternative treatments for people using opioids on an illicit basis or non-medical basis want to, of course, tap this vast untapped market. And even though they said in the deposition that these medications are not indicated for the treatment of pain, and we know that most likely, in most cases, they're not effective for the treatment of pain. And of course, that's my personal experience. We also have the issue of asset forfeiture and the DEA arresting physicians and taking their properties, tax, monies, cars, whatever they can get out of them, even before they have a conviction in the court of law proving that these assets were gained from quote unquote illicit distribution of opioids. And we have the government agencies who want to continue with this narrative and get funding for their departments. And we have now the government agencies inserting curriculum into the medical schools. And then we have new curriculum developers. And there's just a whole chain that comes from the government. Mind you, government interference with the practice of medicine is strictly prohibited by 42 USC section.
Right. No, you're absolutely. Did we lose you there? Can you hear me okay?
We lost him.
Oh, okay. Oh, we're back. Actually, Mark, you're on now because this
Okay.
is exactly what I want. Mark, a lot of the stuff we're talking about here tonight is being published in the best medical journals, the New England Journal of Medicine, the Annals of Internal Medicine, have taken the sides of these views that are clearly dishonest. What do you make out of the best universities, the best medical journals? They've taken this line up. What do you make of this?
Well, I went to the great and powerful Cleveland Clinic for my bypass surgery, and they gave me 28 5 milligram oxycodone pills when I was discharged. I was able to make those last 2 weeks instead of 1 week. And then my cardiologist told me to take ibuprofen. It happened to me. It happened to me post-operatively. I extubated myself in the recovery room because of the agonizing pain I was having from coughing, because they weren't treating my pain post-operatively. So I think it's I think we're in a dark age. Frankly, people have stopped thinking, I'm shocked by it because it seems so obvious to me. It's clear to me, like David said, that the DEA is a piracy organization. They want, they are somewhat, they get to keep some of their ill-gotten gains and they launder it. So, it's insane that they're encouraged to treat doctors like drug dealers. The Controlled Substance Act was designed to protect doctors from the accusation of being a drug dealer. The definition of a drug dealer is someone who sells drugs without a license to do so. The definition of a doctor is someone who prescribes medication because of their training and licensure and evaluations to make and do that safely. Now they have the two conflated, and the profit is basically it's much cheaper to hunt doctors than it is to pay undercover agents to go out and try to buy illicit drugs. Um, we don't we don't shoot back. They know our address and they know that we keep good records, even though they criticize our record keeping. So it is a massive fraud on the citizenry, and the major part of that fraud is that they're too lazy to do their law enforcement work, or they're too dumb to realize that nothing that we prohibit, whether it's alcohol or opiates or cigarettes or abortions, nothing that you prohibit decreases the prohibited activity. It just makes it illegal, and people will go ahead and do that on the other side. So it's we had a 13-year experience in our country and an experiment with alcohol prohibition, and it was an abject failure, and every other prohibition has been also. And they're just lying to themselves and they're lying to us.
Now, let's shift for a moment. We've talked about DEA motives and what have you. Now let's shift to the medical boards. They don't have these same situations. They can't confiscate assets. So why are the medical boards so aggressive in stopping doctors from prescribing, abandoning patients, bad-mouthing opioids? Granted, there's some changing now, but what about the medical boards? Where do they fit into all this? And what's their motives?
Well, let us
Oh.
not forget there is this undertone of this puritanical element in our society that has bought the idea that if you take opioids, that's bad, and you shouldn't be taking them because you might feel a little bit too good. So maybe the medical boards have bought this hook, line, and sinker, and they are on a power grab to make everybody get in line, right? We know that these medications have legitimate uses for many conditions, including intractable pain. So perhaps it is this puritanical idea that, you shouldn't be doing that.
Yeah,
What
good comment.
ahead.
Pat, are you there? Pat,
Yeah, I am. I was
you're
gonna
doing
say-
a lot of work with the California medical.
What Monty and I and Kristen have found with the medical board, at least in California, is, can you hear me okay?
Yeah.
Oh, okay, is that when the enforcement part comes, there's actually two groups that are assessing, evaluating the physician's situation. And one is a representative from the board. It's often the executive director. But the other piece is the person from the Attorney General's office. So you have these two groups that are actually overseeing either the settlement piece or the hearing piece for the physicians that come before the California Medical Board. And we have learned, recently, the more that we're talking to the executive director and to Dr. Thorpe, who's on the board for us, is that there still is a culture variance between many of the people on the board, and not everyone has a warm and fuzzy feeling, as David was saying, toward opioids. So what happens is that the physician gets in this situation where they're before the board, and you can have an attorney for the Attorney General's office who's evaluating them with bias in their mind, and they are wanting to close that case. It costs some money to open that case, to keep that case going. And all of the pressure is they want to close that case, and they want to close that case in favor of what they're doing. And then I'll let others speak. We recently had a case where a physician asked the attorney, why can't you mediate my case? Why are you being so overboard? And she said, I have 3 years to retire, and I am not going to rock the boat. That is actually
That's
told the
integrity.
physician this. I am not going to rock the boat.
An honest DA, huh?
What?
An honest.
Okay. Okay. So it's not peer review. I learned a whole lot. I always thought the board
review.
was peer review. It's not peer review, Dr. Tennant.
I know, yeah. Tell me about it. Yeah. That's
It's
why
not
You
we're,
lack
peer review.
integrity.
yeah, yeah.
No,
Uh,
not at all.
Let's see. I want
Oh,
yeah.
Can I kick in?
God, yeah.
Yep.
Fill me in.
When you ask what the board's where the boards stand, the board's prime directive is to protect patients from bad medicine. And in my opinion, they are failing to protect patients who are being abandoned, forced tapered, and taken off of medications that are providing, that are working. They're failing the patients they are sworn to protect when they are following this, drinking the Kool-Aid of this anti-opioid agenda.
Right. In the time we have left, and you may not have a good answer to what I'm about to ask you, but it's one on why you panelists have been selected by me, because I know that you are concerned. What does the patient today, right now, who's on benzodiazepines, let's say they're taking some Valium, some Xanax, maybe they're taking some Vicodin. What is your advice to patients right now today who are a chronic pain patient, who are taking benzodiazepines and or an opioid? What do they do right now? Do they start tapering themselves? They try to get off? What they try to get a pump put in? What are they going to do right now? What's your advice?
You certainly don't want to advise a patient to go off benzos on their own because it has so many risks during the tapering. I mean, Dr. Ibsen and Scott can talk more about that, but you certainly would never advise a patient to do that unless it's a very managed situation. Should they start tapering their opioid? I mean, I think, honestly, I think it's inevitable that everyone will get caught in that trap if you're taking both. But I wouldn't advise a patient to stop if they didn't need to. No.
Pat, and we're going to try to do this. As you know, in this country, we've got to have some force that, for good, for patients' welfare, and dealing with all of these motivations, which are malignant and they're harmful and dishonest in many cases. So where do we go from here? How do we go about trying to protect patients, get them some help? Where do we go from here?
It's got to be one-on-one. It's got to be the hearts and minds of individuals. And that's why I'm wearing the pin today, is hoping it's a pin for the campaign to protect people in pain. And it hopefully will bring conversation to people. When people see the pen, they'll have that conversation. Well, why are you wearing it? What is that? It's a difficult position. I wouldn't say every advocate is going to feel as comfortable as I do having conversations. But if ordinary day-to-day chronic pain patients don't start talking, we will never get out of this hole, because it is in fact the public that's against us. The public has already shut us out. We have to have that conversation, as difficult as that is.
Yep. And we do want I do want everyone to know where to get these pens, and maybe Jamie, you can put that up there. Well, thank you very much. Now we're going to continue these same questions next week, and but I do think that I ask everybody, what does the individual patient do? What does the doctor do who wants to help? Where do we go from here? Uh, and anyway, Pat, can they get those pins or any information from the group, the protective group? How do we do that?
Oh, yes, I'll give Jamie the link to get it. It's actually a person who has a eBay a company that makes them, and she puts all the money back into making more pens. And I'll get the eBay link. They're not, they are $5 a piece, which is a lot for a lot of people, but she gives instructions how you can make your own. Just need the ribbon and you can easily make your own pen. So we'll get that link out to everybody, how you can purchase them or make them yourself if you want to do that.
Um,
We
okay.
have a very creative board here now. And one thing I think that could be very useful would be, Dr. Tennant, you and I have talked about this, and I haven't taken any action on it, is to create a handbook for people who've been cut off, with what they can do with over the counters or what they could do to create other
Yep.
support. Basically, what I say, and I'm not putting this in writing, is if you've lost access, the cartel will treat your pain. They're happy to treat your pain. They're not so good at the quality assurance part of it. So you have to become a pharmacist and an ICU in order to get your pain treated in that way. That means they have apnea monitors on phones now. You can get a baby monitor. You divide your medications very small amounts. You get fentanyl test strips. You get Narcan in case you need it, but you never use it because you'll never need it. That's another money-making scam we can talk about another time. So our patients have to know that we have been kicked into Sherwood Forest, and we have to do Robin Hood medicine until sanity or King Richard comes back from the Crusades, one or the other. So I think the insanity of it is that we're on our own, and it's time for us to acknowledge that we're on our own and help each other with whatever will float to keep our heads above water until we can get this thing straightened out.
Yeah.
This
And
is David. Oh, Dr. Tennant, I'm working with an author who has a Substack account already where she publishes Substack articles, and she is creating articles about the recent notice that I sent to Department of Health and Human Services, and we are going to publish articles doing deep dives, and we're going to share the Doc Talks videos on there, and we want to make short videos about patient stories in order to begin to have a platform to fight the propaganda. So that's in progress.
yeah, David, one very good. We want to bring that to us. However,
There's another deep diver here, and that's Dr. Norman Clement, and he's been publishing some deep dives also.
I guess where we're at, and to close it out by, we have to give individual patients some guidance right now. What do they do, regardless of whether you're living in Florida or Minnesota, wherever? What do you do if you are currently on a benzodiazepine or an opioid for your pain? Those are the two drug classes they're after. And then secondly, what can we do maybe collectively as a group with other advocates in the country? So what do we do? Would everybody put their thinking cap on this week, talk to each other? We've had some hard lessons tonight, such as the public probably isn't with us, motivations of our medical boards and enforcement agencies is not a pleasant story. And we all know this, but so we'll go from there. Again, thank you so much for being here. And we will close out, and don't forget, we've made great headway in treatment. People are getting better. If they'd leave us alone, they'll get even better. So with that, we'll close out, and thank you again for being here. Thank you for new panel members. Put on your thinking caps, and we'll see you next week. Good night.
See you next week.
We hope you all have a great night and please stay alive. Please stay with us. You are not alone. God bless us, everyone. We will talk to you next week. Thank you so much. Good night.
Good night,
Thank you.
Jamie.
Thank you,
Thank
Jamie.
you, everybody.
Thank you, Jamie.
Thank you.
Yes, yes,
Thank y'all very much. Great show.
beautiful.
Mm.
Love you guys. Stay alive.
You. Yes, stay alive.
Prayers for everybody.